In this video, I'll be answering viewers' questions. Don't turn away because that starts right now. Hey! Howdy! Thanks for learning about MS with me, Aaron Boster. I'm the founder of the Boster Center for Multiple Sclerosis, where we care for families impacted by MS from around the globe. We accept all major insurance carriers, and we're currently actively enrolling for clinical trials. Kelly writes in, Dr. Boster, I am curious your opinion on the ability to use serum lab work as markers for subclinical disease activity, HS-CRP, uric acid, etc. If somebody has abnormal levels, does this mean possible disease activity despite stable MRI? Well, Kelly, you are talking about the future, but the future is almost now, because we are on the cusp of having a blood biomarker to help guide us into response to therapy. Now, it's not uric acid, it's not CRP, it's a lab called neurofilament light chain. And neurofilament light chain is very, very exciting and almost prime time. It's not available commercially just yet, but I think it will be in the next few years. In a quick summary, when you have a neuron and it breaks the axon, the long sticky outy part, if it cracks it, all the stuff inside the axon gets spilled out into the milieu. And that includes several neurofilaments. There's neurofilament heavy chain, neurofilament medium chain, and neurofilament light chain. It turns out that the blood concentration or the blood level of neurofilament light chain correlates with disease activity in MS. So if the neurofilament light chain blood level is high, there's a high likelihood of disease activity. Before an attack, it goes up. During progression of disability, it goes up. And when there's a poor response to a medicine, it goes up. We've seen situations where someone's not on a medicine with MS and they have a high neurofilament light chain in their blood. They take a low efficacy medicine and it drops some, and then they take a high efficacy medicine and neurofilament drops a whole bunch. So we are really on to something very, very exciting. It's not prime time yet, but it will be very soon. And I look forward to integrating neurofilament light chain into my decision making. I think it's going to result in a much more sensitive and accurate approach to dealing with MS. We're going to know a lot more before it's clinically relevant. And so we'll be able to identify, hey, that drug's not working for you, and shift before you ever have new spots on the MRI and before you ever have a clinical attack. Needless to say, I'm super excited, and thanks for the question. Carolyn writes in, SPMS, 17 years, no relapses, no change on MRI either. What's the best disease-modifying drug? So, Carolyn, thank you for writing in. And to be blunt, I can't answer your question because I don't have nearly enough information. I would have to have a much better understanding of your disease course, how you've progressed in disability, when you've had attacks. I need to look at the progression of your MRI over years. So when you say no relapses, first of all, that's fantastic. But I ask, have you had anything else happen? Have you failed the litmus test of life? Have you had progression of neurological disability that's taken away your ability to participate in activities? When you say no changes on MRI, that's awesome. And I assume you mean no enhancing lesions. Have there been any new T2 lesions? Have you had any new T1 black holes? Also, tell me about the rates of brain volume loss. Have you had your brain volume looked at, and is it getting smaller at an accelerated rate? These are very relevant questions, and they'll help us in picking a disease-modifying therapy. Now, there may be some MS docs out there that say, oh my goodness gracious, you're doing so well, let's not bother. And I'm not one of them, because I am a believer in the concept of PIRA, progression independent from relapse activity. And I know the clinical trials data that suggests that when you treat MS, you slow PIRA. So you can slow progression of neurological disability, which is independent from attack. And I want that for you. We also have MS disease-modifying therapies that can slow brain volume loss. And this is separate from decreasing attack rate. And so if you on your MRIs have evidence of brain volume loss, which is accelerated, I probably want you on a medicine to slow that down. I can think of several medicines that would do what I just talked about, and we would try to match up the right medicine for you. I hope that you have a conversation with your provider because they're going to be the best position to help guide you through this decision. I really appreciate you talking with us about it and giving me a chance to share my opinions. Hagen Veenan, and I really hope that I didn't butcher your name, and if I did, I'm really sorry, writes in, "Hi, Dr. Boster. I have some liver damage after my treatment with Mavenclad, and although it's mild, I'm concerned about how well I would tolerate other disease-modifying therapies in the future, as well as steroids, all on top of my symptomatic meds. Is it common for MS patients to accumulate liver damage due to all the treatments, and how is that dealt with?" That's a really great question, and I'm sorry to hear that you had some liver damage associated with your Mavenclad. Now, when you talk about liver damage, we have to actually get into the details of exactly what's going on, because many medicines, and I'm not talking about MS medicines, I just mean medicines in general, are processed by the liver. And it's possible that when you check liver enzymes, the liver enzymes will be elevated. And that reflects mild damage, but it's often transient. And so my first thought is, if your liver enzymes went up, your LFTs elevated, have we been tracking them and hopefully we're watching them come back down? If they come back down in a normal range, I am much, much less concerned. And I'm not thinking that we have long-term permanent liver damage. Many of the MS medicines, as you point out, are metabolized by the liver. And so it's appropriate to check liver enzymes periodically on those drugs. And most of the MS medicines do have a very small risk of bothering the liver. And if we identify that the liver enzymes go up, oftentimes we can delay, stop, or change the dosing of the drug to let them come back down. I have not, in a decade and a half of managing people impacted by MS, seen cumulative liver damage become a problem which limited our ability to treat the patient. I have not seen that. And it's my hope that you're not in that position either. The key here is two things. One is openly communicating with your doctor and making sure that your doctor is checking liver enzyme labs so that we can keep close tabs on how your liver is doing. The second thing is to appreciate that each drug has a different mechanism of action and may be processed in the liver differently. And so it's not as if we keep attacking the liver in the same fashion. And so it's my hope by changing drugs and by monitoring, we can keep you safe while treating your MS. Awesome question. Thank you for asking. The Butterfly Jen shares, "I recently started having seizures. Are seizures common alongside MS, or is it just a fluke?" Well, the Butterfly Jen, I'm sorry to hear that you've been having seizures. And I'm delighted in knowing that most seizures are easily controlled by taking one anti-seizure medicine. And I hope that you have an easy time having your seizures treated. It turns out that people impacted by MS are at much higher risk of having seizures compared to the general population. One paper I remember, it actually said it was 6 times a higher risk. And it actually makes sense when you think about why. MS causes brain damage, and it can cause brain damage on the cortex, the surface of the brain, or on the tissue just deep to the cortex, where all the information goes down through the white matter, the wires. And when you have brain damage in such a fashion, it can set up an electrical short or electrical storm, which is the underpinnings what starts a seizure. A seizure is basically inappropriate electrical activity that builds up on the surface of the brain, like an electrical short in the wiring system on your wall. As such, we see seizures at a higher frequency in the MS clinic than you would in the general population. Queenie97 writes in, "Does MS lead to mental illness or exacerbate underlying mental illness, such as bipolar, depression, etc.? Thank you so much. I really love your videos." Well, thank you for the kind words, Queenie97. People impacted by MS are actually twice as likely to experience anxiety, for example, or depression, for example, as compared to the general population. It's so common that I think it's a best practice that at every single visit, you screen patients for anxiety and depression to make sure that we're not missing a mood disorder. Mood disorders are very easily treatable, and we don't want to let them go untreated because they color everything ugly, and there's some evidence that untreated depression can actually drive MS disability faster. So we want to jump on top of it. If you'd like to hear more questions and answers about multiple sclerosis, click the video that's on your screen right now. My name's Aaron Boster, and I want to thank you for learning about MS with me. Until my next video or my next live stream, or the next time I see you at the Boster Center for MS, be safe and take care.